Hey everybody, welcome back to part one of Neurology for the Non-Neurologist lecture on seizures and status epilepticus. So after stroke, seizures are probably the most common inpatient neurologic disease. Things you definitely want to get familiar with because you're definitely going to see it on our service. So as with my usual disclaimer, remember Neurology for the Non-Neurologist is built to help you succeed on our rotations, but it's not an all-encompassing review of the entirety of neurology. So we're going to be covering a lot of things in these two seizure lectures. But it's all going to be at a pretty superficial level. As always with these lectures, they're not intended to teach you to be a full-fledged neurologist. We're not going to dive into the weeds. We're also not going to really be touching on the magical squiggles of EEG, even though they are pretty cool. What we are going to be doing, though, is working to define and classify epilepsy, discuss important things in the history taking and exam of seizures, discuss seizure workup and treatment, and then finally spend a couple slides talking about status epilepticus, at least enough so that you're comfortable managing until backup arrives. So the first thing to understand about epilepsy is how to define it, and then the different classifications associated with it. So by definition, a person is diagnosed with epilepsy if they have 2 or more unprovoked seizures. So this means we do not count several types of provoked seizures, including febrile seizures, those associated with substance use or withdrawal, ones caused by metabolic derangements such as hyper or hypoglycemia. And then again, you need at least 2 seizures. So we always say that everyone gets 1 free seizure in neurology. Once you've diagnosed a patient with epilepsy, then you must determine if they have partial, also known as focal or generalized epilepsy. And this simply refers to where the seizure starts in the brain. So if they have a seizure that onsets in one area of the brain, either as identified with exam or EEG, then we call it a partial seizure. Whereas if they have a seizure that involves the entire brain from the beginning, then we call it a generalized seizure. And then furthermore, partial and generalized epilepsy can be broken down into their own categories. So within partial seizures, you further classify seizures as either being simple, which means they don't affect cognition, or complex, which means that they do have an altered level of consciousness. And so for example, a patient with complex partial seizures may just have involvement of a specific part of their brain, so just thus will only jerk maybe one arm, but because it's a complex seizure, they're also going to have a loss of awareness, so it may manifest as staring spells or automatisms or things like that. It's important to define if partial seizures stay partial or if they have what we call secondary generalization. So this means that initially they have focal involvement of part of their brain and body, but then later develop a generalized seizure involving the entire brain. And then generalized seizures, on the other hand, so there's several types of generalized seizures, even though I listed only a couple here. The most classic type is the generalized tonic-clonic seizure, or GTC, which is probably the seizure that the general population is most familiar with. And this is a seizure where the entire brain is involved, and the patient first has tonic stiffening and then rhythmic clonic jerking. These types of seizures are very dangerous, both in terms of damage to the brain and also physical injuries that can be incurred with them. And then further generalized seizure types to be aware of include isolated tonic seizures, where the patient loses consciousness and stiffens up severely, as well as atonic seizures where they completely lose tone in their body and falls to the ground. These are also known as drop seizures. And then finally, absence seizures, while not typically associated with motor symptoms, are generalized seizures just because they involve the entire brain at once. And while these are only the basics in a long list of epilepsy types, it can be difficult even to just keep these straight. But that said, it's really important to be able to differentiate between seizure classification, primarily because it's going to guide our anti-epileptic drug selection, which I'll talk about later. So one of the most important things we do in seizure patients is just take a really good history. So not only is it helpful in determining seizure classification, as I was just discussing, but it can also help you rule out mimickers such as syncope or arrhythmia, and also can help you look for provoking causes of seizure as well. So when taking a seizure history, you want to always ask what happened directly before the spell and directly after. So symptoms like lightheadedness, tunnel vision, orthostasis typically are signs of syncope and can mimic seizure. And actually, you'll see that syncope can actually be even associated with brief episodes of jerking or incontinence as well. On the other hand, patients with seizures typically have no prodrome, or they'll have an aura, things like visual or olfactory hallucinations, such as the smell of burnt toast, or things like a general feeling of uneasiness or fear. In the same fashion, knowing what happened after the spell is also really important. So people who have syncopal or rhythmogenic collapse often come to really quickly, versus people who have a seizure will typically have a very delayed return to baseline, and this is known as a postictal state. And then make sure you ask about associated injuries such as tongue bite, which is most commonly seen on the lateral side of the tongue, especially in GTCs. Incontinence, which, like I said, can happen in syncope, but is much more common in seizure. And then posterior shoulder dislocation, as those injuries are almost strictly associated with seizure. And then finally, of course, make sure you're discussing any other associated symptoms that just can help you determine the cause and rule out provoked seizures. So while the physical exam following a seizure is basically the same as your standard neuro exam, if you're lucky enough to witness a seizure or you're able to discuss it with a witness, you really want to focus on the exact sequence of events that occurred. And this is because the series of behavior, which we call semiology in neurology, is really helpful in letting us classify the seizures like I just talked about, but it also helps us localize partial seizures. And we don't just do this because neurologists love the localized lesions. It's actually very helpful in guiding interpretation of imaging in EEGs. So lesions that cause seizures aren't always obvious. And so if you're able to hone in on a suspected region of interest, you may catch subtle structural or electrographic changes that you otherwise may have missed. One important thing to look for when you're attempting to localize seizures is that the eyes and heads will always turn away from the seizure. And this is because the frontal eye fields, which are located here, their role is to push you away from the seizure. So this picture on the right, this one on the left you may recognize from the stroke picture where you look toward the stroke, but in this one, here we have a seizure. This area is revved up, and so this large amount of activation here on the right is able to overcome this little amount here and force the eyes away from the seizure. We call this an eversion. And like I said, this is opposite from what you see in a stroke, where you actually look towards the stroke because the frontal eye field on that side is damaged. And then another important area of epilepsy localization is temporal lobe. And part of that is just because it's the most commonly implicated region in partial epilepsy. So temporal epilepsy manifests itself in some pretty interesting, some pretty strange ways. This includes things like olfactory symptoms, autonomic fluctuations, severe feelings of fear, rising epigastric sensation, and more. Some of these you'll notice are similar to auras, and some epileptologists actually think that auras actually are just partial temporal seizures, but that's kind of a discussion for another time. Of course, and then not all seizures are epileptic in nature, so you should be aware of red flags, which may be signs of psychogenic non-epileptic spells, or PNES, which we previously referred to as pseudo-seizures. So PNES, it's definitely can be disturbing to witness for both family and friends and also untrained staff, and so you may be really pressured to treat these episodes, but just know that benzos and AEDs have side effects, and you can actually do significant harm to treating these people, so it's important to be able to recognize PNES. So instead, the best thing to do in an acute non-epileptic spell is just keep the patient from harming themselves and protect their airway. So one of the highest causes of morbidity and mortality in PNES is actually iatrogenic causes related to intubation. So again, really keep an eye on that airway. After this is done, then your goal is just to reassure both the patients and all the witnesses that they're in a safe environment, that people are closely monitoring them, and that things are going to be all right. And it's really just this reassurance in the acute episodes that's best. Chronically, then, these patients should be treated with cognitive behavioral therapy. Sometimes we'll use SSRIs and other meds as well. But the disease, honestly, is very difficult to manage, and it really takes a good epileptologist and psychiatrist to work through with them. When you're witnessing one of these spells, there are a couple of clues you can look for that may let you know that it's psychogenic in nature. So for one, people with seizures typically have their eyes open and may have an eversion, as I just discussed. If the eyes are forced closed or if they're rolled back in their head, then this is less likely to be epileptogenic. Next, look for asynchronous movement of the limbs. So seizures are always associated with a very rhythmic firing of the brain and muscles. And so patients jerking should follow a rhythm. If they're either speeding up or slowing down, or if two extremities don't really line up with each other, then you may be dealing with a psychogenic spell. And finally, psychogenic spells are often coachable. So if you're able to talk your patient out of their spell, or you're able to change the semiology by talking to them, it's unlikely this is an electrographic seizure. Of course, all that said, there are bizarre forms of epilepsy which can appear very psychogenic, and so really the only true way to make this diagnosis is by capturing an event when the patient is hooked up to EEG. I included a reference here to an article from the Journal of Epilepsy that discusses something called the teddy bear sign. So the authors of this article made note that adult patients who have a stuffed animal in their room are actually 4 times more likely than other patients to have psychogenic spells rather than true seizures. Obviously, you don't want to be using this as a definitive clinical clue, but it's an interesting study, I think. Speaking of teddy bears, this is my parents' dog, Maisie, who's basically a living, breathing teddy bear, which is pretty amazing. She's kind of a legend. Okay, so let's move into seizure workup next. But before learning that, you actually have to have a basic understanding of the causes of seizures. So there's several things that can cause seizures. One helpful mnemonic, if you like those, is AEIOU TIPS, which as you can see here stands for A, alcohol withdrawal or anoxia, E, electrolyte disturbance, I, infection, O, overdose, U, uremia, T, tumor or trauma, I, insulin, which can be either hypo or hyperglycemia, P, psychiatric, and S, which refers to stroke, subdural, subarachs. You definitely don't have to memorize this list, and nor is it an all-inclusive list. In fact, if you look to the right, actually 2/3 of patients with epilepsy have an unknown or genetic trigger. But that said, if you can have a basic understanding of this list, then you can make sense of kind of the workup we do for seizure, which again I'm going to discuss in a second. Before moving to that, though, I do want to touch on something. As you can tell, a seizure in any of these settings would actually be considered a provoked seizure. Remember, if we go back to our definition of epilepsy, you must have 2 or more unprovoked seizures to be diagnosed with epilepsy. And the reason we do this is because we don't anticipate non-epileptic patients to have seizures if we can control their risk factors like drug abuse or hyperglycemia or electrolyte disturbances. But that said, if a patient has a lesion in the brain, like the ones that are asterisks here, things like tumor, trauma, stroke, bleed, or meningitis, and there's actually a pretty high chance that they're going to have another seizure. And so we will actually opt to treat these patients even after their first seizure. Okay, but so let's move on to the workup for the first-time seizure patient. So if a patient with no known seizure history comes into the ED, the first thing they need is a non-contrast head CT to rule out a bleed that would need to be addressed emergently. After this, you should obtain a basic metabolic and infectious workup, including glucose, CBC, LFTs, renal panel, UDS, UA, and a chest X-ray, just to rule out a number of provoking causes we have just discussed. And then at this point, if the patients actually return to their baseline, then the remainder of the workup really can be done in the outpatient setting. This includes an MRI with and without contrast. We want contrast here because it helps us look for infectious or neoplastic causes of seizure. And you specifically want thin coronal cuts through the hippocampus and the mesial temporal lobe. As you can see here, mesial temporal sclerosis, where that left hippocampus is very narrow, is a very common cause of seizures. We also want a routine EEG. We always start with a routine 20-minute EEG, and we can always escalate in the outpatient setting if we're really suspicious. Of course, if a patient is not returning to baseline or if they have any focal neurologic deficits, the work needs to be performed urgently inpatient, and this includes often continuous EEG if you suspect status epilepticus, and then fever meningismus or a history of immunosuppression would probably push you to be more aggressive in your workup and prompt LP to rule out infectious etiologies. And the workup of a breakthrough seizure patient, it's very similar, but in these patients you can actually be even less aggressive in your workup. I had an epileptologist tell me quite frankly once that people with seizures seize, and this doesn't mean that we write off their seizures. It doesn't mean we don't take them seriously, because we do. Seizures, of course, are very dangerous, can be very debilitating to patients. But that said, if a patient with a known seizure disorder has a typical seizure for them, you don't need to reinvent the wheel, get a new MRI, EEG, and LP. Instead, it's more about figuring out why they had a breakthrough seizure and reversing that. So to do this, you should do some of the same basic workup you would always do. So this would include probably getting a head CT just to rule out a bleed, and then definitely getting basic metabolic and infectious workups. And then another really important thing to consider in breakthrough seizures is medication noncompliance, or actually underdosing of their medication. So while this chart to the right is a little small and hard to read, you can see that by far the most common cause of breakthrough seizure in a known epileptic is actually missing doses of medication. And the good news is a very correctable cause, pending patient compliance. So you definitely don't want to forget about it. So while some AED levels come back in hours, others take days to come back, it's usually worth ordering any of the associated ones at presentation and then titrating up on meds and educating the patient as appropriate. Again, you don't really need to repeat the MRI, LP, EEG, unless the patient is either having atypical seizures for them, they have other abnormal neurologic deficits, or there's a concern for status. And that's all for this part of the lecture. So we discussed how to classify seizures. We talked about how to take a history and physical on them, how to perform a basic workup for them. And then in the second half of this lecture, we're going to talk about pharmacologic and non-pharmacologic management of seizures, and then also the neurologic emergency of status. So we'll see you then.